So I'm going to talk just 3 little snippets on insights and origins of metabolic damage in type 2 diabetes, which I believe are relevant to the topic of metabesity and senescence. And I do have dualities of interest, but really they're not particularly relevant here. There is certainly a delay on moving on. So first one, effects of glucose concentration insult are very long term in humans. And the way this has been looked at, of course, is to look at what happens if you weaken that insult with, on the left, monotherapy for microvascular endpoints in UK-PDS, on the right for diabetes-related death. And it doesn't matter about the statistics for the moment, but I think you can see that in both cases we're not getting clear effects for, 8 or 9 years on the Kaplan-Meier curves. And I think we're going to see the same thing with other insults from high substrate exposure. And of course there is a corollary on that, and that is the so-called legacy effect, that once you've had your long period of decreased exposure to substrate excess, then that goes on giving you benefit compared to control, certainly for another 6, probably another 12 or longer years. Look, myocardial infarction on the left, study end, 0.84 central estimate. After extension at 17 years, with glucose control the same in that period, 0.85, it becomes statistically significant, but only because more events are accumulated. On the right, we have DCCT in the EDIC observational phase, no difference in glucose control, but the cardiovascular outcomes separate dramatically because you've had a 6-year later onset for them, probably an epidemiological effect. So this is going to mean that your studies of drugs against metabesity and senescence are going to have to be rather long-term. Then hyperglycemia is a model of effects of substrate calorie excess, the subject of a recent paper. As Ralph said, there's a classical division of what are called long-term complications into microvascular and macrovascular in diabetes, but a better classification might be microvascular, which is glucose-specific, and pansomatic damage, generalized acceleration to multi-organ systems, echoing that of senescence. So here's your macrovascular disease, and okay, this accounts for a huge part of the morbidity, mortality, but actually all these things which you will recognize as issues in senescence are accelerated in people who have hyperglycemia, although the problem of course being they're also in type 2 diabetes mainly exposed to excess calories as well. And you know, I tick off several of these boxes without diabetes myself at 71. In my patients at the clinic, I see a lot more cognitive decline, cataracts. These things are all enhanced compared to age-matched people without diabetes. There are things that are important. Maculopathy, not microvascular retinopathy, is the major cause of blindness. Type 2 diabetes, progressive renal impairment. People often lump it together and call it diabetic nephropathy. Actually, most in type 2 diabetes is not classic type 1 diabetes diabetic nephropathy, but much more similar to the progressive kidney impairment of senescence. So I think we have issue. Most of the organ tissues, of course, in diabetes are not insulin dependent. They're not dependent on insulin, so they see the higher glucose. They're seeing a higher substrate load, just as though you were overeating, and that's true of fatty acids as well, because there's higher release of fatty acids from adipose tissue. So the situation is analogous to the acceleration of damage from X8 substrate due to overeating. My last snippet really is an attempt to explain insulin resistance, and it gives a little bit of a different emphasis to it from that we hear from Ralph. But we know that if you take people who have diabetes, really quite marked here, fasting a plasma glucose of 8 millimoles per liter or 160 or something milligrams per deciliter, and you stop them eating, the diabetes goes into remission in 1 week. And that's because hepatic glucose output falls back to normal in 1 week. And that, of course, is not due to a change in obesity, because obesity doesn't change significantly in a week. And that reminds us that diabetes is not caused by obesity. They are co-caused by excess calorie intake. And it's not caused by a decrease in hepatic fat, as you can see at the top. That does fall more quickly, but you're still double normal at 1 week. So what is going on? Well, we think it's something more to do with the liver. Of course, your substrate load comes from glucose, from fructose in the diet, from pyruvate and lactate, from muscle glycogen, also secondary from the diet, then from fatty acids from diet and adipose tissue. And what you see if these are in excess is that there is a block to glucose uptake when we eat. So where does it go? It goes into the circulation, and you get hyperglycemia. As a result of other changes which occur in the liver, however, you also get continuing excess output of glucose, as actually Ralph showed in the fasting state many decades ago. So how does that occur? And this is a nice simplified diagram of Laurinaitis' paper. Dietary carbohydrate giving glucose and fructose in the blood up there and passing into the liver through glucose kinase into glycolysis, or more directly for fructose, and on, of course, to metabolism. But the pathway into the Krebs cycle is limited. It has to be. The liver cannot consume more calories than it needs. If you like, at crudest level, it would overheat. It would certainly get into problems with NAD and the like. So if you have excess carbohydrate, dietary carbohydrate, you're going to get more fructose, more glucose in glycolysis, and that actually begins nuclear mechanisms which actually promote the delivery of glucose into the blood and block via glucose kinase the uptake. So you get more glucose going into the blood, which is okay if you can dispose of it elsewhere, i.e. you don't have diabetes. But if not, you'll get hyperglycemia. The secondary effect of that, of course, is that you'll get stimulation of insulin secretion. The secondary effect of that is that insulin works on the liver to increase fatty acid synthase, so you'll get more hepatic fat. Get more hepatic fat, and the process of hepatic fat includes fatty acid intermediates and the like, which lead to inflammation, as well as excess triglycerides going out into the periphery and somatic inflammation. So that's the origin of hepatitis and the origin of inflammation, the origin of the dyslipidemias, as well as the hyperglycemia and the insulin resistance, since here metabolism is actually, if you like, a homeostatic mechanism protecting the cells against the excess dietary carbohydrate. So just to finish then, analogous homeostatic mechanisms will occur in skeletal muscle, giving you skeletal muscle insulin resistance, islet B cells, giving you problems of insulin secretion and adipose tissue. So to call this insulin resistance, I think, is a bit of a misnomer. It's rather like saying, you know, the engine in my old Ford isn't working properly, and if I measure that by pushing the gas pedal, I've got gas pedal resistance. You haven't. You've got a crap engine in your old Ford. We've got problems in our tissues, and of course the insulin can no longer work properly, so we measure that as insulin resistance, and we have hyperinsulinemia, and that may have consequences as well. So some insights into what is going on. Thank you.